It's still good morning, everyone. I'm the only one between tea session. So I think I'm hoping me and my panel is going to finish in half an hour. So my name is Dr. Umar Yousuf. I'm a consultant endocrinologist at Shifa International Hospital and also head of the endocrine department. I'm also the joint secretary of Pakistan Endocrine Society. And I'm going to invite my panelists. So I'm first going to invite Professor A.H. Amir. He needs no introduction. He is currently working as professor of endocrinology in Peshawar. Initially, he was heading Hyderabad Medical Complex, and now he's heading the Khyber Girls Medical College endocrine department. He's also the past president of Pakistan Endocrine Society, immediate past president of ACE Pakistan chapter, and currently vice president of South Asian Forum for Endocrinology. My other panelist is a dear colleague. We were trained together in Birmingham, and we were the frat mates as well. So it's Professor Ariq Rahmat. He's a professor of diabetes medicine in Birmingham. His interest is actually type 1 diabetes, pumps, transplant, and is a very dear colleague of mine. So, and Adrian here was unable to join us. So if he can just go for the slide presentation, please. Okay, let me just start with some facts. So, how many of you, and okay, this is politically trickier. I think politically not a correct question I'm going to ask my audience. So forgive me specifically ladies, how many of you are 50 years or above? Please raise your hands. So only Dr. Musa is, okay. If you are at age 50, your lifetime risk of an osteoporosis fracture is 1 in 2 women and 1 in 5 men. And here you can see on this table, it's fine. So 50% of women, of course, at over age of 50 will develop osteoporosis fractures, 20% of men. The lifetime incidence of hip fracture in women is 20% and in men 10%. X-ray evidence of vertebral fracture is 27% in women and 11% in men. And vertebral fracture clinical, 15% women and 8% in men. But then what does that mean for the community? So if you develop a hip fracture, 1 out of 5 will die within a year. 1 out of 5. So just if out of a population of, say, 250 millions, if half are women, and out of them, I would say half might be 50 years above, we're looking at about maybe 1 or 2 crores, roughly, who might develop an osteoporotic hip fracture, and out of them, 20% will die within a year. And 50% unable to walk unaided. And for vertebral fracture, which a lot of us might be thinking is benign, look at their 20% 5-year mortality. 5-year mortality is 20%. And 6% will be having chronic back pain. So, Prof. Amir, these are the facts. And let me start with a story. When I came in 2016, Pakistan Endocrine Society annual meeting was in Islamabad, and there were 2 workshops. One workshop was on insulin initiation and titration, and it was me and Usama who was doing that. And one workshop was on osteoporosis, and it was Arshad and Shiraz who moved back to UK. And no one turned up in that osteoporosis workshop, not even a single person. Everybody attended the insulin initiation and titration, which was conducted by me and Usama. So my question to you is, why it is so neglected in our community? What do you think are the reasons? Is it we are not doing enough?
Thank you, Umar. Is that the reason why Shiraz moved back to England?
I think he was so despondent that
Right.
that's enough.
I'm not surprised, but thank you for bringing up a very important point. And I think one of the reason we have seen the healthcare approach to this kind of a workshop. I'm going to example what you've just quoted, and it just shows the interest. Maybe part of it could be our fault as an endocrinologist. We haven't generated enough interest, or shall I say, it's not interesting enough for our endocrinologists to go and attend this, or maybe people think we know it all. But one of the other reasons I would, and I would see if what Ali has to say about it, and it'll be good to have his opinion as well, that maybe I think we need a multidisciplinary approach. And the reason for that is we have seen in PCOS now that we are integrating with obs and gynae, and we are getting a lot of breakthrough in that, because a lot of women with infertility or many other problems would go to gynae. I think same applies here, that a lot of our patients with a backache or with other bone pains will go to orthopods. And I remember one of the incidents, maybe I think it was 2012 or something, that there was a conference of orthopods, Orthocon, and they invited me, and I was kind of surprised. What do I have to do this? And they invited me for osteoporosis, which was only one time I remember. So I think maybe a collaboration will yield more. The knowledge of our healthcare professionals will be, uplifted, and awareness among the public will be generated. And I think if we are to, or for that matter, if PES has to do sessions related to osteoporosis, I think involve the orthopods into it. Bring them in. Get it inclusive. And it might help our cause to be more into osteoporosis. And I think same was the case with PCOS, and I think same is the case, I don't know how you feel about it back in UK.
Yeah, no, thank you for asking me to join you guys here. I think if you look at the UK system, osteoporosis is managed by a number of different specialities, and I think that is probably one of the reasons why it almost gets neglected, because everybody thinks they can do it. So you might be working in a center in the UK where a rheumatologist is working who's got a special interest in bone health, and he actually does the osteoporosis clinic. Or you might be working in a center where the endocrinologist has a special interest in bone health and does a clinic. I think the important point is it's everyone's business. That's a really important point to take. The second thing is almost everybody here would also be a general physician in some way or another. And actually an important point is, as part of a general physician and anybody who does general medicine, you will come across this a lot in general medicine as well. And certainly one of the big areas in the UK which is working in this area is what is the ortho-geries specialty, or the care of the elderly physicians that actually look after people admitted to hospital with fractured neck or femur. I can assure you there is not much from the surgeons on osteoporosis management in the UK as well. And it is mainly with the physicians, but it depends on which center you work in. So in our center, we've been lucky to have one of the very sort of renowned people like Professor Neil Gittos in our center in University Hospitals, Birmingham. So there's a definite tendency for us to look after more osteoporosis because of him. And we've all been trained by him. You, yourself, Umar, and me both were trained by him. So we've developed that interest in osteoporosis, but that might not be the case at a lot of other centers, even in the UK.
So, Amir Saab, I think you're lucky that you were invited. I mean, Abbas told me a story that when he moved in and he was asked to give a presentation on teriparatide, he was introduced as a time have come when an endocrinologist is going to tell surgeons how to manage osteoporosis. So at least from that point, you were quite lucky enough. Ali, coming back to you, what do you then think? Of course, so I think it's a multidisciplinary approach, and it should be everybody's business. I think it should be the primary care and the medicine, because they are the ones who see the bulk of that, and then think about it and think about how to risk assess. So who should you think sort of is in general population? How should we target our general population for assessing fracture risk?
So I think every women over the age of 65 and every man over the age of 75 should be screened for, and we should manage them and look for signs of osteoporosis. And then anybody under the age of 65 in women and under 75 in men who have risk factors, we should also look at screening them for osteoporosis.
And where you can get those risk factors from?
So the risk factors, you can basically get them from the history, essentially. You can look at their medications. They might be on some medications long-term which increase the risk. They may have other endocrine conditions which might predispose them to the risk of osteoporosis. So you need to identify all those risk factors. In terms of how we screen them, I think the crucial thing here is, and we will discuss that in more detail, is about the availability and how you actually do the DEXA bone density scan, because that's an important avenue which we need to use appropriately and properly screen with that investigation.
And I found actually, I mean, from the risk checker, I mean, this is a website that I found quite interesting. We can go on the website and then find out. It's just like a reminder about what to do. So you have mentioned about sort of basically the DEXA scan, and Amir Saab, I'm coming back to you about the DEXA scan, what are that's involved, and do you think sort of basically that from a DEXA scan point of view, we should have a standardization? Because I find it difficult when you are having a DEXA scan from one lab and then from other lab, that they're completely different. So what do you think regarding DEXA scan? What are the problems currently in Pakistan regarding the DEXA scan, and how can we rectify that?
Yeah, I think it's been used sparingly, but I think one of the reasons is that there's no standardization. The machine, the reader, how to analyze it is not standardized. And you can do a scan from one center and then do another scan from another center. That will show some difference. And how quickly you do it or how delayed you would do it, I think that will be a key as well. You don't want to do, DEXA every 3 months, because that's not going to yield anything. And I think that's an important point. So I think from perspective of education and from perspective of what Pakistan Endocrine Society is doing, I think it will be very good that we invest in a DEXA scan in terms of education. And we need to educate our junior colleagues, we need to educate our general practitioners as to what to do it from one center, do it at an interval at least a year, in some cases when you're treating maybe every 2 years, standardizes, do it at one place, and I think that will yield. And reading what scores are you looking at a 1, 1.5, 2.5, what scores are you looking at? So I think that needs to be done, and I think I will incorporate in that one of the easiest thing to do is the risk assessment, and that is FRAX system. You can have a FRAX scoring system just like Framingham, and the FRAX can tell you that what is your risk of a hip of that particular patient. And then when you incorporate BMD or DEXA into it, you'll get a better yield of the prediction of your patient, whether he or she is going to develop, and then whether he or she needs follow-up or treatment, and so on and so forth.
And I gather FRAX is ethnicity specific as well, and you do need a DEXA scan for that. Are there any other risk scores as well?
If you don't do BMD, DEXA, then you can do a Q score, but how sensitive it is, that's questionable. It will show you a percentile, and high risk and moderate and low risk. But I think FRAX still holds better because you've got a lot of assessment. Ethnic, that's questionable. There was a question about the Asians, about the blacks, Hispanics. There was an article, I think, in 2020 in New England, which specified it. But whether, we don't have, for somebody to have ethnic specificity, you need to have a fracture rate, you need to have a mortality rate incorporated or registry. Unless you have that, you can't make it ethnic specific effectively.
So our problem is we don't have Pakistan specific risk scores. I think that's important, and that's where I'm so much proponent that we should have a local data and incorporate that. So there's a Q fracture score, there's a Garvan 2, there's FRAX, but in FRAX. So what in terms of figures for FRAX? So just give me a reminder about the figures you're looking for over.
Yeah, 3% or more for a hip and 20% or more for other risks,
Major.
other facts is the score which you are looking at.
So early, I mean, one of the problems that I'm actually seeing in Pakistan is, and I remember one of my patient and she called me and she was quite upset because her 15-year-old daughter have been diagnosed with osteoporosis because she came with the general aches and pains and somebody did a DEXA scan and based on that, the T-score. And I'm thinking, should we actually ban arranging DEXA scan in children, or how can we address that? So I think it's important, I mean, if you can
So I
shed
think
a light on that.
if you're doing a DEXA scan in children, then you have to be very clear that you cannot define osteoporosis in children, and what you're actually relying on is what is the Z-score or the Z-score, which actually is measuring it for that age. So you cannot really then start comparing it with a normal adult and signify that that child has got osteoporosis, because that is just going to increase the anxiety unnecessarily and absolutely unnecessary. So I think the Z-score is what you're going to rely on if you're going to do a bone density scan rather than the T-score. I think the important point is what Dr. Amir said earlier in terms of making sure there is some standardization, because that's what is crucial for you to be able to look at the correct T-scores and Z-scores for your population.
And I believe that the DEXA scan for children should be the remit of, say, rheumatologist or maybe endocrinologist, and they decide rather than primary care. Because I remember as a registrar with Neil Gittos, I did audit on the development of osteoporosis clinic service, and that part of that in children, the DEXA scan is a part and parcel of that. So yes, there might be some role, but it should be a remit of the specialist for that. And coming back to, I mean, Amir Saab just mentioned that unfortunately in Pakistan we don't have the standardization for DEXA scan. The courses are not there, and I think as a community, maybe in association with other societies, we should be thinking about that. What about the status in UK?
So I think the Royal Osteoporosis Society does a lot of work on that, and there are some courses which are available, both basic and advanced fellowship courses. So I think that's a good avenue that could potentially be explored.
So it's the same website?
Yeah, same website.
And I think their foundation course is free, but their PG certificate you have to pay for some.
Yeah.
Okay, so that's quite helpful. So Amir Saab, I think this is where, what do you think as an endocrinologist we can brought in terms of osteoporosis? What do you think the causes we should be looking for? What do you normally, when you see someone and you have your endocrine hat on, what are you thinking about, what to rule out?
Yeah, I mean, the age is one, as just mentioned, 65 and 70, but then a lot of other causes, or shall we say secondary causes, and I think since day before and yesterday, all the talks were done on pituitary diseases, on thyroid, on, but I think the main thing, what you is that it should be at the back of the mind when patient comes to you with aches and pains. And I think that should be kept in mind. And as you've just mentioned, Cushing's in our society is very prevalent. There will be people who are on some sort of drugs which nobody knows where they got it from. So for us, Cushing's is the main, and then obviously you need to investigate on those lines. But then the diabetes itself is a risk, and that's a high risk that need to be looked into. Acromegalic, and there are chronic illnesses like Crohn's disease, colitis. So I think what I would suggest is that if you've got these causes, which you have very nicely written up here, I think a history is of foremost importance. You take a correct history, you will yield into some sort of pathology, whether the patient has got some secondary causes or not, and then followed by investigations, a CBC, a liver function test, a renal function test, a thyroid function test, or just a screening test would be a good tool to start off. And maybe a bone profile, vitamin D, I'm not too sure whether we should be doing vitamin D in every case because it's pretty expensive. It's better to treat, in my view, rather than, if the calcium is fine, just treat them.
Yeah. I have a question for that, but not for you. I have got another question for you. And I'm going to ask a trick question. So this is a trick question. And both of you can help each other. So I always find it difficult if I see a 70-year-old lady or 80-year-old lady with hyperparathyroidism, and one of the indication is their DEXA scan. If it's less than minus 2.5 T-score, you can offer them surgery. But then I think, is it because of the postmenopausal or is it because of hyperparathyroidism? So what do you do in that case?
Well, this is a trick question. I agree, simply because you've got a hyperparathyroidism in that age bracket. But my question would be, and that question will be very pragmatic to myself, that whether I'm going to treat that hyperparathyroidism, which is mild, I don't know, it's severe, it's got a complication, organ damage or not, and sometimes we just sit and watch it. But as far as here we are talking about the bones, so if the bone is an issue, then I think it's pragmatic to treat that bone. And I think I would treat that bone and maybe look at the non-weight bearing bones and just treat it. The treatment would be the same whether this is osteoporotic or whether it's hyperparathyroidism. That's going to be the same.
Because you can medically.
So that's a more practical approach.
But I think that's where I found the radial BMD. The only time when I find the radial BMD might be a bit helpful.
Better. Yeah.
Otherwise, I normally think about looking at hip and the.
So I think certainly when I'm requesting DEXA back in the UK for primary hyperparathyroidism, I do actually specifically ask for, please comment on the radius so we can compare it with the other bones and see how it's impacting it. So I think that's useful. The second thing is, I think it depends on if you're going to proceed with surgery based on other factors such as raised calcium or not. Because if you're not, then actually the management is the same. You are going to actually treat them in the same way, irrespective.
So, Ali, let me just come back to, I've been mentioning a lot about DEXA because I think that's a real problem. But what about the bone markers? And I'm just going to whiz past it because I don't think so we have got bone markers in Pakistan. Maybe one odd lab might be doing that, maybe one more. What about the scenario in UK?
There are some available bone biomarkers. I cannot remember the last time I found them particularly useful in a clinic setting for osteoporosis. There are the markers for bone absorption, bone resorption, both. So there are things like osteocalcin, which you can do. There's N-propeptide, telopeptide you can do. But actually, from a practical point of view, when you're managing osteoporosis, routinely we don't really utilize them. It's more of an academic tool which sometimes can be helpful. If you're struggling with the actual making the diagnosis, and it's straightforward osteoporosis but another condition, that's where perhaps the role of the biomarkers and just making sure you differentiate between which markers would be for resorption and remodeling would be the important point to remember.
So coming back, I think that's the investment part. Diagnose the osteoporosis and you're thinking about, say, treatment, and we knew the first one.
Actually, I can't ask you guys to do that. Now, the most important thing is, even in the UK, when I'm checking vitamin D levels, it is extremely rare that I come across a normal vitamin D in somebody who's not taking supplements. So actually making sure that people are taking vitamin D replacement is, in my opinion, more important. But prior to that, checking their calcium levels to make sure you've not suddenly got a hidden case of sarcoidosis which you've made worse by giving them vitamin D preparation is the most important thing to check prior to that. But yeah, no, even in the UK, I don't think, maybe it's because of where I practice. As I said, I practice in the capital of British Pakistan in the UK, so I come across a lot more vitamin D deficiency than perhaps in other areas.
Ahmed Saab, coming back to the bisphosphonate and the Pakistani perspective, what do you think? What's your go-to bisphosphonate? Do you go for arendronic acid or zoledronic acid? Because I will come to my practice later on, but what is your go-to?
Coming to vitamin D, it sounds very interesting and music to my ear. We've done some study, and I'll just mention that. And we've done some statistical analysis. We are in the print right now, and we've come to understanding that in a healthy, absolutely healthy young individuals, you will not see a normal vitamin D in many cases. And I think I'm just starting to question that, is this vitamin D good enough? Shall we be testing really And I think it's a waste of resources. In my case, I think it is a waste of resources, as you just mentioned, in our population, unless you really are pressed to do it for one reason or the other. And the cutoff levels we have calculated, and hopefully when it prints, we think 30 is not for us. I think the study and the calculation we have done, I think it's probably much less than that which is required, and maybe we are overestimating, and we've calculated with the statistical scoring, it's around 15. But coming back to your question, I think the usual scenario is bisphosphonates, you need to treat. But looking at our scenario, and there were sessions yesterday as well, the follow-up of the patient, the side effect profile, the two problems in our population, पेट का मसला तो सबको है. So whether we are adding more problem to the patients, the GI side effects, zoledronic acid, yes, expensive, but it's once a year, you give it, you forget about it. So I think that's more pragmatic, at least a follow-up. But there are cases for both. You can give, weekly, monthly, or yearly. I think it's a choice of a physician what they want to do.
I think it's a choice. It's an interiorization which is the key. Yeah. And again, coming back to your vitamin D thing, that's why I'm a big proponent that we should have local level data. Our diabetes is different. True. Our vitamin D is different. True. I think our everything is going to be different from a Caucasian. True. So that what we need to think about. Ali, how long do you prefer to give bisphosphonate? I mean, do you want to give a holiday breaks or?
Yeah, so I think in the UK the recommendations are to go for the weekly preparation first, and if they don't tolerate it, then we go to the zoledronic acid, or denosumab is the other option as well, which we sometimes use in the UK. I think the only comment I would make there would be to make sure that there has been some sort of assessment of the teeth, because obviously the risk of the osteonecrosis of the jaw, making sure they are in reasonable working order. You probably find it easier to see a dentist in Pakistan than in the UK. It's not at all easy to see a dentist in the UK, I can assure you of that, but that is something which I would recommend. But yeah, denosumab is probably being used a lot more by us now, and I think it's something which is available every 6 months as opposed to annually for the zoledronic acid. But it works very well, and certainly we've used it a lot.
So, I mean, denosumab is not in our setup, but I think we have maybe odd patient on. So, where do you find denosumab more helpful?
So, I think firstly, if there is an issue with the tolerability of the zoledronic acid and alendronic acid, that's where you might find it more useful. Also, at the moment, there is no suggestion that you need to go on a drug holiday, for example, from denosumab, which there is for zoledronic acid and for the bisphosphonates. So those are some of the more practical elements where denosumab might be useful. And then I think a very important one is, because we're seeing more and more now the risk of osteoporosis in people with kidney failure and chronic kidney disease, and denosumab is one of the medications which you can use at GFR under 30, probably one of the very few which you can use in osteoporosis in CKD.
So that's another trick question I'm going to ask later on. Amisa, but we have teriparatide. So where do you use teriparatide?
Yeah, I think the first line drugs are always there, but if we find that they cannot tolerate it, that's where the teriparatide, which is available in Pakistan, we can use. It has got the good thing, it has got both the property, anti-resorptive and anabolic, so that's a plus point for it. So yes, we use it, but once the other are not tolerated, or if there's a generalized osteoporosis and it has got a good effect both on the long bones and the spine, which I find it better for our patients if you want to use it.
So yeah, I'm just going to sort of basically, because I've got just a couple of questions, so we're finishing soon. When do you repeat DEXA scan then after the treatment?
So, I mean, we normally actually don't repeat DEXA scan until at least 3 to 5 years. And certainly I would not repeat at all within 2 years. So there is no real need to repeat DEXA prior to that.
And I gather it's important that it should be the same lab or the place where you have first DEXA, so that you can compare it rather than from a different.
I mean, the point here is, if you're using it, for example, in a post-menopausal women for osteoporosis, and your working is that you're preventing fracture, irrespective of the bone density scan, if they haven't fractured, that means the drug is working. So you could look at the bone density scan, but also practically and clinically, If they haven't had a fracture, that means the drug is working.
So last order basically is, I think you mentioned about CKD, so you can use denosumab. What's new in the treatment?
So there are a couple of new drugs which are coming around. So there's a newer one for teriparatide, the ibuprofen, which is coming up, and also romolozumab. I've struggled to pronounce that even, but that's the another which is a monoclonal antibody which is coming on. And I think the advantage there would be that as opposed to denosumab, it's supposed to be a little bit better in terms of working on both functions of the bones. So that's one of the things which is coming up at the moment.
So lastly, any piece or final piece of advice would like to give before I can wrap up the session? Maybe take 1 or 2 questions and then we finish. Okay, we'll finish.
Okay. I think from my perspective, what we've been through, the liver diseases and diabetes and all that yesterday, I think that holds true here as well. I think lifestyle is the key. We need to have a healthy lifestyle right from the beginning, and have adequate dietary settings. What you need is a good calcium vitamin D at an as early age as possible, and physical activity. I think from my side that will be. I will not talk about the medication.
And in few lines.
I think these sort of initiatives that you're running now, I think making sure there's awareness and actually working as a society to get the local level data for your DEXA scans, making sure it's validated, your levels of vitamin D and calcium are validated. So we actually are using the appropriate cutoffs for our management.
So thank you both of you for your helpful comments. I think the tea is ready and there are few questions, and I think Ali is a very tough scientific. Yeah, we are late 5 minutes, so you can always ask questions to Ali Kramat and Professor A.J. Chamil during the tea time. There's one question. Well, is good. I think we should be, the tea matters, so we should be back by 11:45 or 11:50? 11:45. So tea is ready. Thank you everyone for the first session, and thank you very much to my panelists.
Thank you, sir.